And hello everyone, I'm Talysha from the Progressive Podiatry Project. You're joining us for the Sunday Roast. Today I'm joined by Kirsty, the Lifting Pod, and Aaron Wilson from Aaron Wilson Rehab. So just a little bit of an introduction, because this is the first episode with all three of us on board, is I am the director of the Progressive Podiatry Project, a continuing education platform for podiatrists, primarily in the area of musculoskeletal podiatry. And I've been a practicing podiatrist for around 15 years now, and for about 12 of those years I've had a special interest in musculoskeletal podiatry and physical rehabilitation of more chronic and complex presentations. And so I'm just going to throw over to Kirsty from the Lifting Pod. And Kirsty, can you introduce yourself?
No worries. Thanks, Talysha. So yes, I'm Kirsty. I'm from the Lifting Pod on my Instagram link, but I also am the director of Imperial Podiatry in Queensland. So we're just a mobile podiatry home visit service, delivering all aspects of podiatry. I guess, real passion for me to go into podiatry was just due to the fact that I love sport, I love exercise, and I have a history in track and field. Also just love the fact that we can take away or assist with pain relief, and that's the main motive for, I suppose, my treatment pathways, and working together with clients to be able to give them a better quality of life. And podiatry is just so much more than what meets the eye. It's not just, cutting toenails. And I think more and more people are becoming aware of the fact that we do actually treat from, the hips all the way to the toes, and it's so complex. So not one size fits all, but hoping today we can get some that misinformation out of the way. So yeah, thanks for having me.
No, it's all right. So I'm Aaron Wilson. The reason why my Instagram is Aaron Wilson Rehab. So not only am I a podiatrist, I'm studying physiotherapy as well as postgraduate, and hence why the name Rehab rather than Aaron Wilson Pod, because it didn't seem right to then have to change it later. And yeah, as you can tell by the rehab, my special interest is rehabilitation, MSK injuries from acute to chronic. So I'm based out in Sync Health, just a clinic out of Marrickville. We're predominantly working in sports injuries. We do general everything, and multidisciplinary as well with physios and EPs. And yeah, as well, just consult online through Instagram in between making memes, if you're aware of those. And yeah, personal background, haven't done anything too amazing, unlike Kirsty. I did play rugby league pretty much all my life, was lucky enough to represent the West Tigers in their lower grades. And now I'm just the guy who could have made it if I wasn't injured. So yeah.
I'm so excited to have, thanks Aaron and Kirsty. I'm very excited to have both of you guys here, because Aaron with his interest and history with football, Kirsty with her history with competitive track. I have a history of just being the perpetually injured runner. So haven't competed in anything amazingly on a competitive level, but distance running is kind of my jam that I've discovered over the last few years, and it's something that I quite often injured with, but it's not usually related to training errors, which at some stage we will discuss. It's usually my lack of spatial awareness and just being unlucky in the house that causes my injuries that I have to rehabilitate myself from. Now, the whole purpose why we've all come together is essentially we're forming what we call Foot Pain Explained. So it's not just for health practitioners, but it's also for the general public, because all three of us have quite a large presence on social media with all of the information that we're sharing and what our platforms are aiming and hoping to achieve. And like anyone who's on social media, yes, it's a great avenue to access information, but with the increasing presence of social media and how much people are utilizing it, there is also an immense amount of misinformation that gets shared on there, whether or not it's intentional, so people are just sharing their biased opinions, or it's just people or practitioners that just maybe aren't up to date with where the latest evidence sits. So the whole purpose of this project that we've come together to create is basically to take some of the misinformation that we see popping up on social media, breaking down why it may not be as accurate as it's portrayed, and then coming up with the actual evidence that supports our arguments and the reasoning why we're disagreeing with what's happening on social media. So just a caveat to this, if we do talk about specific posts, we're not attacking or trying to discredit individual people or practitioners. It's the information that we're discussing. It's nothing to do with the individual themselves. And well, there's maybe the odd one or two people that I'm not a huge fan of, because I do think that they have a little bit of a malignant interest in what they're sharing. But for the most part, whatever we're discussing, it is purely from an educational standpoint. It's not an aggressive take on any human that exists. We're just here to try and help people help people. So the topics that we're going to be discussing today is, we've all picked our latest gripe for the week from whatever's popped up on our own social media feeds. And we're talking about the dirty word that is pronation. And then we're also going to be talking about pronation, footwear, and its relationship to bunion development. And then I'll also be throwing in my 2 cents worth as far as a couple of recent posts that I've seen from certain bigger influencers regarding some pretty heavy duty misinformation regarding footwear and some of the pathologies that they can contribute to. So talking about pronation, I'm going to throw to Aaron first. Give us a little bit of a rundown as far as your weekly gripe for the Sunday roast.
Yeah, so I think it's even fair to say it's my however long many years I did podiatry for gripe was introducing pronation. So everyone knows it. What we think of it is probably different to what it really is, or at least I guess then you could say in my opinion, because people tend to have a different opinion. But one of the first things I taught with gait is the foot hits the ground. It's got a nice high arch. Actually, I'll get my foot out. It's got a nice high arch. It's called supination. It flattens, it's called pronation, then it supinates again as we walk off. And for some reason, and I'm not sure if you guys had the same experience with uni, I think I was about 2nd or 3rd year where apparently that stopped happening. You just hit the ground like that and plod along, and any deviation of that was bad. And that's where the dreaded word overpronation seemed to come from. And everyone likes to say it's bad, leads to injuries. And I've yet to come across a well enough argument where I believe that. And yeah, like that's essentially where the gripe is. So I guess you want me to just keep running with it?
It's, well, I can, so we've, all three of us have slightly different levels of experience. So I'm the grandma of the group as far as how long I've been practicing for. But I can very much say, so when we went through university, even then, so that was, what, 2004 I started studying. So nigh on 20 years, which is terrifying. But yeah, pronation was still considered quite a dirty word then. So too much pronation was bad. And that was back in the era where, especially with footwear, the aim of footwear was to be really supportive and to stop overpronation or hyperpronation. And what I've seen very much in sort of the last 2 decades of podiatric practice and studying is, yeah, there's more and more evidence that's coming out. So lower quality studies, higher quality studies, but all of this research is coming out that consistently shows that pronation is sometimes correlated with the presence of some injuries, but in a lot of injuries, it's not causative. So what that means is basically, yes, some people that sustain these types of injuries, they do pronate, but researchers can't find the link because there likely isn't one. There's so many other factors that feed into it. There isn't a direct link between that person overpronating or hyperpronating and that causing their injury. And that's where another issue comes from, is hyperpronation and overpronation technically don't exist because we can't quantify it. So if we can't measure how much is too much of something, then it just, the limit does not exist. So basically with that, so I might pronate 2 degrees, but for me in my movement pattern, that 2 degrees might upset things, but there's probably other things that are feeding into it. But for Aaron, he might pronate 25 degrees and not have an issue. So it's very much something that is easily blamed for being a causative mechanism for pathology and injury. And oftentimes that's what practitioners, and it's not just podiatrists, like physios or any other health practitioner, doctors as well, they might go, it's because you're pronating too much that it's causing the problem. Very rarely is that the actual problem. So Aaron, I'll throw back to you, or Kirsty, if you have anything that you want to throw into that with your experience.
Yeah, I suppose going through uni, I think you're sort of taught in a little bit of this, I don't know, tunnel vision phase of the paradigms. And that's kind of how, as your brain, you know, as you learn as a health professional, where you get your resources from. So I don't know if you guys remember, you know, the root paradigm, or, you know, Kirby's, you know, subtalar joint access and things like that. But I think that's where it kind of all like took off. And I think that would have been like, you know, the 1980s and then the 2000s, of where, you know, you got a neutral sort of axis. But what is neutral? Because that is so variable amongst, you know, populations. And then I suppose the question is, what is a pronated foot type? Because for someone, that could be a really comfortable position for them. So then I would say that is a neutral position because it's comfortable. And it's not, as you said, it's just a factor in their, you know, makeup. It's not necessarily a bad thing. So I think there's just a lot of variance in when the word pronation comes about. It's not an isolated, you know, diagnosis or anything like that. It's so many different, I suppose, avenues we can go down in regards to pronation. But for me, being someone who is, you know, a pronated foot type, as a kid, I wore orthotics, and as a podiatrist now, I don't wear orthotics because I've learned to, you know, build up those, I suppose, muscles in the layman's terms to, you know, perform at my best. And when I do need, you know, extra support, that's where, you know, Aaron comes in with his awesome, you know, sock rehab and things like that, where, you know, you've got exercises that you can help rather than just putting in something to, you know, cure it, I suppose. But yeah, it's a bit of a tricky one because a lot of people will look at it and want to fix it, but it's not about being fixed. It's about just an observation rather than a diagnosis, I suppose. So yeah.
And that's a really good point that you made, as far as it's an observation, not a diagnosis. And that's one thing that I'm sure both of you will agree on. And it's one thing that shits me to tears is pronation isn't a diagnosis, where if someone's told that you pronate, that's your pathology, that's your problem. Like, pronation is a movement, it's not a diagnosis. So like, we don't tell someone that you supinate and that's the name of an injury, or you abduct and that's the name of an injury. Like, it's literally just a description of movement. So Aaron, just because you're the biomech man and you've got the foot sitting with you, can you explain probably a little bit more about why it's actually necessary for gait, and like walking gait and running gait?
Yeah, so my big thing with that comes from, so if you look through research, especially when they use force plate and data like that with the running, you actually see that most of the force produced into the ground is when the foot's in a pronated position. And now that's my first thing that turned my head in early years of uni, is, well, because we're taught, well, the foot's a mobile adapter, it hits the ground, goes floppy, therefore if we hit a rock, we don't stumble. And then the foot goes nice and rigid to push off the ground. But even when you think of other muscle groups, you know, if you're doing a bicep curl, the hardest part of the work is probably at the start or at the middle. When you're at the top and it's in its shortened position, nothing's really going on. You're just kind of there. And it's the same story with the foot. The foot hits the ground. It's, you know, it's generally a bit rigid. And even if it's flat, it's still quite rigid. People neglect that. There's a lot of bones in here that lock up regardless of whether it's flat, high arched. And when you hit, you know, with gravity, with force, as we're trying to propel, it hits the ground and it's got to continue to push into the ground, regardless, again, whether, like I said, if it's flat. And it's that period of time where we're pushing into the ground. And if you want to get flashy and start throwing out Newtonian laws, like number 3, every action is equal and opposite reaction. To be able to get off the ground, you got to push a lot harder than you're coming into the ground. So therefore, the forces from the ground push you forward. And in doing so, that generally happens when you're in pronated position, because that's the point in time where your foot is no longer elongating and we're starting to get that stretch contraction and that elastic recoil. And the simplest way to even just physically view it is if you try to jump as high as you could with allowing, you know, in the most natural position, you'll probably find you pronate, you internally rotate, something to that degree. Then if you try to externally rotate everything, really grip your feet out, like twist your feet, have that high arch that we're traditionally led to believe is perfect, and try to jump as well, you probably find it feels like shit and you don't get really high. And somewhere along the way, it still hasn't seemed to translate to that because, like we already spoke about, yeah, everyone just sees this foot from behind doing that and go, oh, that's bad, that hurts. And yeah, you just watch any marathon runner, any sprinter, and their foot does that, and no one bats an eye. And I like what you said about, like, it's highlighting it is a movement, and you know, you could use the same premise for every other movement in the body, and it just doesn't make sense. You know, if someone started, you know, walked a certain way, if you started saying, oh, they're an internal rotator, probably go, okay, well, what does that mean? But then someone goes, oh, you're a pronator, and it's yikes, that's an issue.
Yeah, it's all of a sudden associated with all of these bad terms. And that probably, this is slightly segueing from what we were planning on talking about, but it still fits the narrative, is like when we see, there's two pictures in particular that I hate, and they're both related to each other. So it's often images people use to advertise orthoses and whatnot, where you've got one foot that's just a cartoon foot, or it might be a real human foot. By the way, it's a picture of the back of the foot, and it looks like it's collapsing in quite a lot, and it's overpronating. And then they have, and it's got the sort of bendy line saying, oh, and it's usually a red line because red's bad, right? So someone's just standing naturally, and then they've got this foot that's rolling in. And then the next photo was them standing on an orthotic device, and there's a nice vertical green line that's there. And that's often used to, I think originally when those images were first developed, it was probably just a way of sort of trying to communicate something complex quite simply, but it's just been bastardized to the point where it has fed into this narrative that pronation's bad and you need to have this vertical or rectus or supinated looking and functioning foot to function okay, which isn't accurate. And then if we zoom out from that, the picture that follows on from that usually starts at the feet, but there might be one side of the body that it's all nice and straight and it's all straight lines, and then the opposite side where we've got all of our red lines, and you've got a foot that's rolling in, a knee that's internally rotating, a hip that's dropped, a shoulder that's dropped. And that's often used as a, yes, you need to have an orthotic to give you this vertical posture. And it just, so many things. And we'll talk about knees and internal rotation another day, because it's something I know you two know a significant amount about between sports and powerlifting, how much knee valgus and its relationship to movement. Yeah, we'll get into that another day. But have you guys because I've seen those pictures a billion times in the however long I've been practicing for. Are they two pictures that you guys see quite regularly popping up?
Yeah, quite a lot. And yeah, it's funny because what we fail to realize when we look at them, because on paper, yeah, it looks cute and looks great. Like, okay, red, bad, green, good, nice little fix. But the whole point of, you know, assessing like gait and foot and all things like that, we're moving, and and that's my one thing I don't really follow on to is, yeah, postural assessment, because posture is only as good as how you've held them, how you've stopped them. So if I look at your foot, leg, ankle, whatever it is, I'm seeing it right now in this exact moment. The moment you take a step, whatever I've just looked at, assessed, is out the window, because it won't come back, because that's been left there behind. And the same can be done with any of those photos. You know, oh, look, you're red here because, you know, you're twisted in. As soon as I take that next step, or if I position you slightly different, the whole thing changes. And I can probably guarantee for most people, you can get that perfect green line anyway. And that's actually something I want to ask, since you've already said it. So Kirsty, you said you've got a bit of a more typically pronated foot position, and you had orthotics as a kid. Did it fix it?
Funnily enough, it wasn't even for my my foot. It was actually for my knee at the time. And from memory, it's hard to diagnose myself because it was when I was about 10 years old. So I'm assuming I had some sort of, I don't know, Osgood-Schlatter's or something like that, that age bracket of osteochondrosis. I'm not 100% sure, but I do remember it feeling better. But at the same time, I was out of them within probably 2 to 3 years. So, what's to say it was the orthotic, or was it to say I grew through puberty and built that strength myself? It's a debate probably for another day, but at the same time, exactly right though. A lot of the time you just go, oh, pronated, here's a pair of orthotics.
Sorry, is your foot still the similar position?
Probably worse. Yep, probably more internally rotated.
And there's just one point I wanted to put on with that. So none of what we're saying is orthoses are bad. So orthoses, they certainly do have a role as far as altering load. So Kirsty, even for you, it may have at that point in time been what you needed to change the loading mechanics of the foot when you were walking or running. So I think the point that we're all sort of trying to make, because none of us are anti-orthoses, we all prescribe orthoses. We're just all, I feel, very considered in our prescription of orthotic devices. So I think what we're trying to probably call more attention to is, one, the misinformation surrounding pronation, and then how by health practitioners across the board, and not just health practitioners, like even footwear stores, for example, because some of them do like to upsell inner soles as well. So it's just the pronation, the misinformation surrounding it, what it is, what it's bad for, what it's good for. And then also how very easy it is to blame that and then use that as justification for prescribing an orthotic device. So yeah, I feel that we're probably all on the same page that yes, there is a role for orthoses. And sometimes what we're doing is trying, when we're prescribing an orthotic device, to control, or not, well, we can't really control, to alter some of the forces, which may be pronatory related forces going through a foot for specific injury management scenarios. But yeah, we're all on the same page as far as orthoses aren't bad, and pronation sometimes is something that we do address in a script.
And even then, like to back to what I was kind of saying before, like when you look at it from the position of forces and what we're doing there, rather than what the positions are, you'll come across that, because the commonly question then I get thrown at in disagreement when I say some of that is they go, well, this person has pain and they pronate, and they get pain worse when they pronate, so therefore pronation is the problem. And because if in their opinion they stop it, change it, whatever, and they get results, they fixed it. And like talking about it before, it's the position where most force is generated into the ground. It's the position where most tendons in the foot are at their most elongated position functionally in gait. So there's a lot of force, there's a lot of length. And, when you look at other injuries in muscles, we know muscles tend to get injured more at that lengthened position. And they also tend to get injured when there's more force put through them, because there's a demand that needs to be reached and in a lot of cases exceeded. And that's kind of how, sometimes with it, you don't have to throw the baby out the bathwater and change the whole dynamic by saying, well, pronation's now good, which it is. You just kind of got to tinker with the lens a bit, because you can make modifications to that, but we're not fixing them or reducing the stress because we've just simply changed the position. We're simply just changing the amount of force that has to be applied to get the outcome, which is essentially just load management, just with flashier words.
Yep, I very much agree with that. And it, so just because we'll jump on to the next topic in a minute, but just sort of expanding a little bit on what Aaron said. So yeah, when people are in that sort of maximally pronated or lengthened position, there is a purpose for that, because our muscle tendon units, their job, how it works in gait, is to store and release elastic strain energy, which is the same with the plantar fascia. So we need to have load applied into the tissue. So if you just think of it like an elastic band, so it's got to be applied in there to get that stretch so it can recoil to help propel us forward. So that's the whole purpose of it. So if you're trying to eliminate something that you actually need to have an efficient walking or running gait, then you're not going to have an efficient walking or running gait. So sometimes it's just modifying the load that's happening into a tissue to a point that we can calm it down so the body can adapt, so you can keep moving forward. Pardon the pun, but
yeah, 100%. I think I learned that quite early on, I suppose, at uni, when I think we were on a placement once, and a physio I sat in with was like, okay, what do you see the difference between this sort of standing foot posture and then, you know, when they're walking? And the answer to me was very simple. I was like, they're completely different. And he's like, exactly. He's like, you can't take, you know, that standing posture, you know, what we're talking about, that static, you know, SPI, you know, your foot posture index that, you know, everyone loves referring to, and then say that they've got that highly pronated foot, because when they're in, you know, gait and, you know, in watching their mechanics and in analyzing those three sort of phases, then it looks completely different. And I don't know about you guys, but I've seen a lot of patients that, you know, statically they look pronated, but then when they walk, they look more supinated. So it can be completely different functionally. So I suppose it's like form versus function, and not trying to treat the, you know, the presentation on a static level, because do we stand still for our whole life? No, we walk around and, you know, we sit down and we get back up, and going from a seated position even just to standing, you know, we need those muscles. And I think I've said before to Aaron as well in one of his posts around our anatomy, like the foot is so, I don't know, it's constructed and engineered so specifically that, you know, we have that certain amount of ligaments on that medial aspect for a reason, and that is to pronate. So you've got to have, you know, a variable in there where I suppose it's hard because you have a spectrum, I suppose, of movement, and maybe that's why we have these terms of overpronation and whatnot, because people go, oh, they've kind of fallen out of that area, or they're an anomaly or whatever it may be, and so they're classified as different or abnormal. But realistically, who are we comparing it to? Are we comparing it to the patient, or are we comparing it to a population? So I suppose just looking at the patient as a whole, and not taking one factor and saying that that's what's wrong with them, because yeah, it's definitely not that way inclined.
Yeah, definitely. And it's very much like, is it the fact that someone's pronating, or is it the fact that they just normally overpronate? And I'm just using that in quotation marks. So do they overpronate and that's the problem, or is it the fact that they've increased their running mileage by 20 kilometers in 1 week? Like, is it the fact that they have diabetes mellitus, it's not well controlled, that's contributing to the development of their musculoskeletal pathology? There's so many other factors that feed in there that once you combine them all together, some may play a part, but then